Hello and welcome to the October 2021 BJA broadcast. I'm delighted to welcome three colleagues from Denmark who've conducted a really ambitious and magnificent clinical trial, which is going to be the subject of today's broadcast. And just to introduce you to the papers that we're going to be, or the paper that we're going to be discussing today, the BJA October issue, we have the paper Goal-Directed Fluid Therapy in Emergency Abdominal Surgery, a randomized multi-center trial. So if I may ask my colleagues to introduce themselves, and perhaps Birgitte, you could start.
Of course, it will be a pleasure, Philip. I am Bridget, I usually call myself in English, Bridget Brandstrup, and I'm chief surgeon at the Department of Surgery in Holbæk Hospital, and I'm also a research associate professor at the University of Copenhagen. I've been studying fluid therapy the last 20 years or more, actually. First known with the restricted fluid therapy from Annals of Surgery in 2003.
Thank you. And Anne?
Yes, my name is Anne Bohn, and I'm an MD at the Department of Anesthesiology in Holbæk.
Welcome. And another Anne?
Yeah, I'm Anne Moller, and I'm a professor of anesthesia at Herlev Hospital in Denmark. And my main research interest has been perioperative medicine, including the fluid therapy, but not excluding other things. So I'm more broad, I think, in my interest, but still, yeah, perioperative medicine.
Can I supplement a little bit? Anne is a PhD student, and we are both her guides, or how do you say in English? Supervisors.
Uh-huh. Excellent. So, yes, Anna, you were underselling yourselves there. I mean, it's a very special thing for a clinician to be doing a PhD. So that's fantastic. So the title of your paper, goal-directed therapy. I just wonder if you could explain to the viewers what you mean by goal-directed therapy in the first instance.
Yes, of course we can. Goal-directed fluid therapy has been a term that has been used for quite many years. And usually it refers to fluid therapy given to a near maximal stroke volume or a central cardiac parameter. It could be other things. For many, many years, we have used blood pressure, pulse, the clinical state of the patients, diuresis, etc., to evaluate the volume condition of the patient, if they had hypovolemia or euvolemia. However, blood pressure is very imprecise. You need a deviation of about 20% from normal before blood pressure changes. And in that respect, stroke volume is more precise. If you're normovolemic, like you and I, and you lay down, then the blood will return from your legs to your heart, and it will increase the preload to the heart, and thereby increase the stroke volume. So if you're normovolemic and I give you a bolus of fluid, your stroke volume will not change a lot because you already have a very good preload. I can show that on a graph if you like. Then I can share my screen here. Let's see. There you are. Now you shall imagine that if you are hypovolemic, you're down here on the Frank-Starling curve. And then if I give you a bolus of fluid, for example, 200 milliliters, then your preload will increase. And that means that you will go from this point to this point if you are hypovolemic, and your stroke volume, on the other hand, will increase as well. And we used an algorithm using stroke volume increases of about 10%. If the stroke volume increased more than 10%, we gave an additional bolus until it decreased less than 10%. then you know you are on the flattening part of the Frank-Steining curve, and you know that you have, so to say, filled up the circulation of the patient. So that's the idea of the goal-directed therapy, that you can see not only if you're hypovolemic, but also when you actually have given enough fluid to fill up the circulation. So we thought it was a very good idea to give to our emergency surgical patients.
What do we know already about goal-directed therapy, perhaps from other surgical populations?
Well, there are the literature on fluid therapy is very difficult to interpret, actually, and it is very dependent on the control groups. If you have the early goal-directed trials had so-called standard fluid therapy in the control groups, and they all showed a shorter length of stay, but not a very convincing effect on complications or survival. All the fluid therapy trials have the weakness of being, not all, most of the fluid therapy trials have the weakness of being non-blinded. So length of stay is actually a very, very difficult endpoint to rely on, in my opinion. Then others have tried, including myself. In BIA, we published in 2013 the first trial testing goal-directed fluid therapy against zero balance fluid therapy. And when I say zero balance, it's actually a little bit positive balance. We allow the patient to gain up to 2 kilograms from the fluid therapy given during surgery. So it's a little bit positive. Anyway, the goal-directed approach did not add any benefits on the hard outcomes of our patients in that paper. And later on, a Cochrane review has confirmed that. But nevertheless, goal-directed approaches have been wanted to be a part of ERAS, enhanced recovery after surgery protocols, and especially in emergency surgery, it has been advocated that goal-directed therapy was potentially beneficial. However, this trial is the first trial actually randomizing goal-directed therapy in emergency surgical patients.
So were those recommendations regarding goal-directed therapy and ERS based on any decent evidence from your view?
Well, if you go on PubMed and search for goal-directed fluid therapy, you get a lot of hits, and many of them are meta-analysis. Mostly they are positive towards goal-directed fluid therapy, and many of them mix elective surgery with all kinds of elective surgery, because nobody has made fluid trials in emergency surgery before, and I understand that fully after been doing that. Anyway, so we are the first to do it in emergency surgery, and when the result is negative, the argument has often been that our patients were low risk, they were ASA 1 to 2, and if you had patients with higher risk profile, then the benefits of the goal-directed fluid therapy regimen would appear or be more visible. I think there's a lot of different opinions in this field.
Well, when there's lots of different opinions, that really does suggest that the evidence isn't conclusive by any means. So you've mentioned the challenges of conducting an interventional trial in this patient population having emergency abdominal surgery. And I guess you were at the brunt of this in trying to implement the protocol, the study. Just give an indication, if you could, of some of the challenges that you faced in actually doing this study?
Well, what was not the challenge? The patient arrived at the hospital at all times of day and night, and that made us rely on the local investigators being observant and having the time to include and treat the patients. And that, of course, could be a problem in a busy operating room. In addition, the patients were very ill, and we had to include them very fast with a lot of information. And that balance of not doing it of not overwhelming the patients was also a challenge.
I can also tell another challenge. Some of our colleagues would perhaps not include the sickest patients in this trial because they thought they should have the GDT. I know personally at least one physician who has this point of view. So if the patient were really unstable, he wouldn't randomize the patient. He would just give the GDT just because he believed in it. So that's a bias for sure. And I don't know how often this happened. I just know it has happened at least twice or something in my department. But it probably has happened also elsewhere, but I don't know for sure.
I don't think the problem is that big, Anne. I think it is a central Copenhagen thing. We are out in the more periphery of Copenhagen, and our anesthesiologists didn't have those preferences, and they didn't in Odense or Svendborg as well. So
most of the patients were included in Copenhagen. So
yes, that's true.
So I really want to give the viewers an even better idea of the enormity of what you've managed to achieve in executing this trial. So when did you first conceive the idea for it?
Well, that's a long time ago. It was me that conceived the idea, and that was in 2013 when the other trial came out with a negative result, the one published in the BJA, comparing a zero-balance fluid therapy against goal-directed fluid therapy, also with the negative results. And I was very convinced that if the patients were actually sicker, and who is more sick than emergency surgery patients, who has it doesn't make any sense to talk about zero balance in that population because they are absolutely not in balance at all at the arrival to the hospital. So therefore, I was looking for a better alternative of controlling their fluid status. And I really believed that the goal-directed fluid therapy would come out beneficially.
Mm-hmm.
And
so 2013 was the conception.
Yes.
When did you actually start recruiting?
Well, I don't recall. Do you, Anne? Anna, do you recall? I think I have it in the paper somewhere. If you excuse me for a moment here.
I think it's something like 2016. Was that?
Yeah, probably 15 maybe.
Yeah. So 2 to 3 years to set up the trial.
Mm.
And how long had you anticipated it would take to recruit? It was just over 300 patients you were wanting to recruit. How long did you think that would take?
I thought it would take 2 years.
Uh-huh.
But the problem was that, well, there were many problems. One of the problems was that I anticipated that more hospitals would contribute. On the other hand, when it comes to the number of hospitals, my PhD has actually told me that being many hospitals was extremely difficult, that it was much easier to really try to get all the patients from one center or two or very few centers instead of having to control the treatments in many parts of Denmark.
We did discuss that somewhat into the trial because at my hospital, Herlev, we could have actually recruited all of them if all the efforts were put into that one hospital instead of spreading out the energy on 6, 7 sites.
Oh,
because
five
okay,
sites.
but still, you spend a lot of time getting to know people on all the sites. You spend a lot of time getting to the sites, and especially after we realized that the PhD student, had to be there actually in order to make it happen, then it was very complicated with all the sites. But on the other hand, we also got a broader selection of patients from different sites.
Yeah, and I think that is a real strength to have patients recruited from a variety of settings. I think it's always going to give anesthesiologists and surgeons elsewhere more confidence that the results are likely to apply to their patients as well. So if, as we all know, that you can have a highly specialized center and their achievements may not be accomplishable elsewhere.
That's true.
Okay, so the actual study, I mean, one of the features of your process that I thought was really helpful was that you published your trial protocol, and that enabled people to see the protocol and compare it with the results that you've generated. Now, you used a composite primary outcome. What are the benefits and what are the drawbacks of doing that?
Is that for you, Anne?
I can answer. The benefit is that you may not, you need a smaller sample size. That means you don't need as many patients as if you had only one outcome. So that's the major benefit, I think. So the backdraw is that when studying the results, you cannot really say for sure which part of the composite outcome is responsible for the results. But of course, yet you can, because you can look at the detailed results, but then again, you'll probably lose the statistical power. So there are some benefits, and many people use it in order to reduce the sample size because of all these problems we had recruiting. It's difficult to have a large sample size. I don't know what the sample size should have been if we had just taken one of the outcomes in the composites. Did you ever calculate that, Birgitte?
Well, we did calculate to and fro.
Yeah, but it is probably at least 1,000 patients, even more maybe.
Yes,
and that would have been a huge task.
I think that one of the major challenges in this trial is actually that clinical practice changed since I conceived the idea in 2013 towards a more restrictive fluid therapy as a standard. And that means that the difference between the two groups in fluid volume is actually very small. And I think that is part of the explanation of a missing benefit of one or the other. That the actual treatment is very alike. Even though it's statistical highly significant, then the intraoperative fluid difference is only 500 mils. And in the day of surgery, it's about a liter. And it is not a whole lot.
Yeah.
So
you've given the game away a little bit there in terms of the headline finding. So just to emphasize for those people who are yet to read the paper, the headline finding was?
Well, no difference at all.
Okay.
We had a difference in hospital stay, but again, I think that's firstly, it's a secondary outcome. Secondly, it's a non-blinded trial. I think there's a lot of possible bias in length of stay. I would not say firmly that the benefit was towards the standard fluid therapy, and I would not say that goal-directed fluid therapy is harmful, not at all. I would more say that we could not show a benefit And on the other hand, it didn't look like it had a benefit. Perhaps it caused a longer hospital stay. That might be coincidence. I would more or less say that using goal-directed fluid therapy is voluntarily. It doesn't seem to harm the patients as long as you try to keep them in some kind of not more than +2 liter fluid balance.
So probably the length of stay was a random finding, but we don't know for sure, of course.
Of course we don't.
No.
Yeah, that's the wonder of chance, isn't it? We can't. Chance is everywhere, and we can't control it by its very nature. I mean, do you think there were any other potential confounding factors there? Because obviously the patients are allocated to the groups by a random process, but sometimes you get uneven distribution of certain characteristics. Was there anything that when you looked at the data in depth that you thought, aha, this might be something that contributed to the lack of difference?
When it comes to hospital stay, a few more patients, but it's only 30 versus 19. It's a difference on 11 patients. It's not very many. Mm-hmm. But a few more patients had stomas in the GDT group.
Mm-hmm. I was thinking, sorry to interrupt you, I was thinking more in the other direction. Were there any characteristics of the GDT group that might have suggested they had more medical problems, they had different types of surgery, or anything like that?
There were a little bit more diabetic patients, and more of them had hypertension. But
there's also a little bit more septical patient in the standard group.
Yeah, so that should count in the other direction.
Yeah, that doesn't count in the other direction. I know that, but it's still. But
okay, so I mean, it's we can only speculate on these things, but I think they're just it is interesting just to look through and see if there are potential reasons, and invariably there are you never get complete even distribution of patient and surgical characteristics in such a trial. Now, one of the things that interested me is that you included patients having laparoscopic surgery and open laparotomies. Did you notice any signals there about differences in those two groups in how they responded to the different fluid regimens?
No, we made a survival curve that differed or differentiated between the two diagnoses of ileus and perforation, but we didn't look into the type of surgery, did we, Anna? Do you recall? No, we didn't. We could. It could be an interesting question, but laparoscopic surgery is very used in Denmark. And as you can see, we are actually a little bit in front of Great Britain when it comes to emergency surgical procedures with the laparoscopic technique. And I think my younger colleagues are more keen of using the laparoscopic technique, and the more older doctors still use the open surgery. We didn't encounter that there was a significant difference, but the distribution between the two groups that we compared was equal. Mm-hmm. So that's the important thing here. You can always make all kinds of subpopulation analysis, but then you would break the randomization, and I don't think it belongs in this paper.
Absolutely. Which now, from what you've said already in our conversation, I think you might be reluctant to undertake another interventional trial in this patient population. But if you were to do this study again, what would you do differently?
Do you have any good bits, Anna? What should we do differently?
Well, I think it depends again on resources, because that's always the limiting part, isn't it? Because what we would like to do is to include all patients, but that would probably mean we'd need to have somebody at all sites all the time, 24/7, and that wouldn't be feasible, I think. But it would be really nice to be able to include every patient, so that we wouldn't have any risk of selection bias. Mm-hmm. And also to be sure that the intervention was performed correctly in every case. So that's what I would do if I had like 2 million
pounds.
Euros.
You must be in pounds there.
Yeah, pounds or euros, whatever. Lots of money. I mean, an unlimited supply of money, but that's not the case. So it's probably difficult to do it better, I think.
Do you have any suggestions, Anna?
No.
It was the same we were talking about if we had unlimited funds.
Yeah, exactly.
You would place a scholar on each site 24/7.
Yeah, it's certainly people intensive.
It is, and you know what? The major problem is that you only have 3 hours from arrival to the hospital to the patient should be under the knife. And in those 3 hours, you have to set the diagnosis, do the CT scan, inform the patient, give the antibiotics, etc. And then on top of that comes the information on a trial. Mm-hmm. It is really a great demand on the patients. Mm-hmm. And on the surgeons and on the anesthesiologists and on everybody else.
So if you were, having done the study, and if you were to advise colleagues on the place of goal-directed therapy in emergency abdominal surgery, what would you advise them?
Should I answer?
Yeah.
I would say that if they were very comfortable with the goal-directed fluid therapy, it didn't show any harm. But if I must say I'm impressed of my anesthesiologists colleagues, because it seems that they are very capable of looking at the clinical condition of the patient and give the right amount of fluid, and even without goal-directed fluid therapy. So I just think that they are very skilled. I think that's a really good achievement. They don't need the flow-guided fluid therapy to lean on. And I think that's because they are very educated.
Mm-hmm. I think that's such an important point. Well, it's an important point to emphasize the skills of anesthesiologists. But in terms of clinical trials, there are so many clinical trials where I think you mentioned earlier that the control group, the standard therapy group, is not the best possible therapy according to current practice.
That's
so
true.
Yeah, I don't think that we could ever underestimate the need for great attention to detail and application of knowledge to the clinical situation for these very sick patients.
I think you have an important point in the control group treatment, because you can always get a positive result of your trial if you mistreat your control group. Always. And well, that's not just how you do it, is it? I mean, we are doctors, it's our patients, we need to be good to all of them. So
well, unfortunately, I'm sure we all know examples of some high-profile studies where the equipoise hasn't been evident in terms of the groups that have been compared. And yeah, it isn't good practice. But you know, I don't think anybody can accuse you of that, because clearly, as you've said, they were using state-of-the-art standard practice, and clearly applying it very well. Any extrapolations to other surgical populations and goal-directed therapy, or have I already tried to make you speculate too much already?
Well, there's always this point about, are the patients sick enough? And I must say we have national differences. And I live in a very privileged little industrial country with free access readily available of healthcare, and meaning that most of our patients are actually in medical treatment for whatever condition they might have beforehand.
Mm.
And you might get other results if you go to, I don't know where, third world countries, or places where distances are very far, or you have to pay for medical health, or the generalizability can suffer from that, of course. But I think that the Danish healthcare system is comparable to many other European countries. So at least in our own little sandbox, you may say, the results should be applicable.
Yeah, I agree. But yet you do see patients who come in with medical conditions that are not sufficiently treated sometimes. Also because many of these patients with the abdominal emergency conditions are sometimes very, very socially and also physically not the strongest in the country. So some of them are perhaps not sufficiently treated. At least that's my impression after working with these patients for many years. Some of them are really not in the best condition. But in general, you're completely right.
You can see it from our ACE scores.
Mm.
They're still quite low.
Mm.
Okay, so Anne, I hope this hasn't put you off clinical research.
No, not at all.
Good. So if we were to give you unlimited resources, we're still left with this emergency abdominal surgical population. And even in the best hands, as you've demonstrated, there's an important level of mortality and obviously morbidity as well. So if you had the unlimited resources, what research question or questions would you like to address in this patient population to try and improve those outcomes?
Well, I have a few suggestions. Will you start? And you have a few too, I'm convinced.
Well, maybe Anna would like to start.
Is this something you want to
No, that's okay.
investigate?
We talked about it.
I would definitely look into our use of antibiotics. I think the gut microbiome is very interesting, and I think that this standard giving antibiotics to everybody might be more harmful than beneficial in many cases. And it's certainly not evidence-based, at least not in bowel obstruction patients. The only thing you have to support systemic antibiotic use in those patients are actually a case control study from many years ago. So we really need randomized trials in that field.
I agree. But some of the things I would like to look at was the triage of these patients, because I think that, which is also seen from our patient pool here, that they're very different. I mean, there's a big difference between the obstructions and the perforations, and also the condition when they come. So at the moment, all our guidelines, at least in Denmark, is kind of dictating the same treatment for the whole pool of these patients. But I think that some of them could benefit from preoperative optimization more than having fast surgery, depending on their condition, of course. But at least for some of the obstructions, perhaps some optimization would be more beneficial than fast surgery. That's also a thing I would like to look at in a randomized trial. It seems we just did a systematic review on the surgical delay, and actually we don't have any evidence to say that the 6 hours cutoff is actually necessary for most of the patients. So that could be another thing. Should we actually use the time to get the patient better instead of rushing to surgery? Yeah, that's one of my questions.
I think it's relevant absolutely for patients with bowel obstruction without threatened bowel vitality.
I agree.
If you have threatened vitality of your intestines, I think you need to have fast
I agree.
surgery.
But that's why I would
As
look
well
at,
with the perforations who are
Yeah.
increasing in septic condition with the time passing.
Those are really interesting ideas, and I just wish I had the multi-million-pound grant to give you. Anything else that you'd like to add to your shopping list?
Well, don't we all have a lot of things to add to our shopping list? Right now, we are looking into the gut microbiome and their importance for anastomotic leakage. But that's an entire different question. When it comes to emergency surgery, I think the trouble is that the accident, you might say, has already happened, and you have to repair it as fast and good as possible. But the microbe is already on the loose, so you're on your heels and not in front. Like you are in elective surgery, then you are in front and you can more control perhaps any complications. It's difficult when it comes to the emergency surgeries. Okay,
well, thank you so much, and thank you for discussing your paper with me today. And I'd just like to thank you again for contributing such an enormous achievement to the anesthetic literature. And I'd really like to direct anybody who wants to conduct a clinical trial in a complex surgical population to read your paper. There are so many good aspects to it. No paper is perfect, but you know, you've brilliantly highlighted the strengths and the difficulties with your paper, and you've generated a valuable result that is important for all our clinical practice. So thanks again, and thank you to our audience for watching this BJA broadcast. Goodbye.
Thank you. Goodbye.
Goodbye.